Okay. All right, Fran, so just look at me, pretend the camera isn't even there. First, let's pretend we're meeting for the first time. What's your name and what do you do? What's your title?
I'm Fran McConville, and I work on midwifery at the World Health Organization.
Great. So, this report that came out today, I know it was a long time coming. Can you talk about how it got started and just briefly, the history of making this report happen?
Okay, it was a long time, and there's good reasons for that. But it started really because when I arrived at WHO, there was a lot of very good work going on disrespect and abuse of women in childbirth, and that is very worrying. But when we dug a little deeper, we started to think, so why? Why is this happening? And a lot of the blame was being presented as if it was coming from all the healthcare providers, but particularly around the midwives who have the closest relationships with the women. And we know, and myself as a midwife, that if that's happening, then there's something wrong with the system. Something isn't working right, because you don't become a midwife for fun. You believe deeply in the rights of women and the quality of care. So we started to think we need to hear from midwives themselves. And frankly, we discovered that no one had ever listened. And having worked for over 30 years in Africa, Asia, and in the Middle East countries, we know their conditions, and I've been with them. They're awful, the conditions where they have to work. So at the Women Deliver conference in Kuala Lumpur, I put up a sign that said, "Do you feel safe, respected and empowered?" thinking a handful of people would turn up. We presented research from Papua New Guinea, from Afghanistan, Nepal, and about disrespect and abuse as well, and burnout and how people feel. And the room was packed. We couldn't fit enough people in. People were sitting, standing, squeezing in, and over 100 people were queuing up outside. So we all of a sudden realised, at last, here's an opportunity. People need to speak and hear what's going on. So we took that work back to WHO, and we did what's called a systematic mapping of the literature. And we thought we'd focus on the three things that had come out from this first discussion. Was we often focus on the professional barriers. Do you have enough supplies and equipment? And what we found out, that's certainly one of the barriers. But secondly, is as women face enormous amount of gender inequity as childbearing women, but also as midwives. So there are some real social and cultural barriers that midwives are facing that they've never been able to articulate before. And on top of that, some of them just haven't been paid for years or months. And when they are paid, they can't even feed their children. So about a third of them were having to take these extra jobs. So we thought something really is going on here. And we put that all into this systematic mapping of the literature. And it came out with the same. These are very, very serious barriers that are preventing the quality of care, respectful care that women, newborns and their families should be having. And around that time we had the State of the World's Midwifery report that said out of 73 countries, only 4 had enough of the midwives who had the skills. And then we wonderfully had the Lancet series on midwifery, which looked actually at what do women and newborns need, and what do the midwifery personnel need to have to provide that care. So then we took the advantage of the ICM Triennial Conference in Prague, and we had a social anthropologist, and in English, Spanish and Arabic we had about 40-something midwives from a lot of countries, and we did some good participatory mapping. And we took those questions all combined together with a systematic review, and we thought we've got to ask midwives around the world. So we developed these 10 questions, put them with the help of the ICM on their website, and asked them, and their societies helped us to outreach. We thought we'd get a couple of hundred answers, and we got 2,470 from 93 countries in all these different languages. And it wasn't only those who could access the internet. In Yemen, for example, they photocopied it, they went with people, they sent taxis out, they filled it out by hand, and somebody collated it all. So the desire to be heard is absolutely huge. So that's where we got to, and we're really pleased that it took that time, but it's been worth it to really listen to midwives' voices.
Okay, I have one bar left on my battery, so it just went out. I want to make sure I get the policy stuff with you.
Yes.
I think we'll have time, but to come back to some other questions. But tell me, why is it important? Why is it so hard to get midwives at the policy table, and why is it so important that they are there?
I think those two are totally interlinked, and it's to do with gender, status, and the image of midwifery. And women who work with women are often untouchable in parts of Asia, and it's just seen as women's work. It's like cleaning up in the kitchen. You've done it for centuries, you've never been paid. So we don't really need to hear what you have to say. And at the same time, birth has become highly, highly medicalised. So we've had this, which makes it even more important for midwives' voices to be at the table. So it's been normal for midwives just to be told what to do, and policymakers to just make those high-level decisions, and we will tell the midwives this is what they need to do. But when they're not at the table, we've seen this tremendous rise in caesarean sections in countries such as Brazil, women's rights being lost, episiotomy, which really should never be done unless there's an emergency, being done routinely. And these are the kind of things that are going on where we don't have midwives at the table really being very clear that women are healthy and strong, and they come into labour and it's their birth, and we're there to make sure that they're fine, that there's no complications, and to support them to deliver their baby. And that's a different approach to creating policies to medicalise or make sure everybody has an injection of oxytocin, extremely important interventions, but there's a very different approach. So we need both. You know, we need the medical side, we need the midwifery caring side in the policies, so that the midwifery care is the whole spectrum right the way through. We also have examples, for example, to prevent a postpartum hemorrhage, you need to give an injection of oxytocin. Now, if at the policy table there aren't midwives, there are many countries around the world where midwives aren't allowed to give the injection. So we can't change that policy unless they know that, and we actually say things like that. So we really need to not be the only ones at the policy table, but to join the conversation to make sure it's really balanced. And most importantly, the midwife talks about the woman and the baby and the family right the way through. It's not one point in time at the birth or at the clinic. And that's what we need to get into the policy, that the woman and the newborn are really at the centre of this. She needs those interventions, but that's how we need to focus.
I'd love to have you connect this with the quality of care guidelines that are being rolled out by WHO, and sort of that bigger picture of ensuring that women are treated with respect, dignity, that whole quality, equity, dignity piece that we know needs to happen. How can you just talk about that and the role of midwives?
Well, what's been really important in WHO's new quality of care guidelines around the childbirth is, for the first time, not only have we looked at the provision of care, what you do to women, what interventions they need, but their experience of care. So we've looked at their emotional needs, the importance of communication, and respect and dignity as a quality of care standard. So we've now got a much better balance. And what's been wonderful with the State of the World's Midwifery report, this report, the Lancet series, is we've taken the evidence-based language, for example, around the biological, cultural, social needs of women and newborns, and we've put that into those standards. And the framework around it also includes ensuring the rights and dignity of women in childbirth, but also, for the first time ever, I'm really pleased to say, the rights and dignity of the women who are caring for those women. And that brings together, for the first time in WHO and really across the other organisations, the fact that they're both women. Most midwives are women. There's some great male midwives as well, but most midwives are women, and they're often pregnant and are delivering at the same time as the women that they're caring for. You know, we're all together, and that they face the same barriers. We know that women have faced barriers of transport and all sorts. Midwives face the same barriers, and it's about bringing that together. So I'm really pleased that the WHO guidelines have taken this really holistic approach, the provision of care plus the experience of the woman, but also the experience of the midwife, making sure that she's okay to provide the quality of care that the women and newborns need.
Okay, now I'm going to go back to the report and talk about some of the major findings of this report and what they mean, what they tell us.
Okay, I mean, the findings really show, to start with, that this was the first time midwives have had a voice, given the numbers that came through. They also throw up the barriers. It really consolidated that they are facing professional plus sociocultural plus economic barriers. We didn't fudge that, that really came out very strongly from their voices. But they also showed us they have the solutions. And the solution that came out so strongly is, if you listen to us, if you involve us, we can solve a lot of these quality of care problems. We're there every day on the ground with women. We can overcome them. But often you develop solutions without us, then they don't work. And we're the ones who are carrying them out. So we want to work with you. So the main finding really is to let midwives speak, to be heard. When policy decisions are being made, make sure midwifery leaders are there. That the solutions include not just looking at professional barriers, not just giving a delivery kit, but making sure that midwife has a delivery kit, she's paid well, and she's socioculturally supported and accepted in her community. So the findings show that getting us to that table, listening to our voices, really will make a big difference for the quality of care for women, newborns and their families.
And it will also improve outcomes, right? The health outcomes.
Once the quality of care moves, we know that. Once it starts to improve, women survive, thrive, their communities transform, as do their children, as do their families. And midwives have always very much been part of women's lives, part of their communities. So it uplifts, it's empowering women in childbirth, but also women as midwives. So whole communities are uplifted and transformed when we work together like this.
Perfect. Thank you.